Now, Mohan, our worldwide its prevalence, 850 million people worldwide have diabetes, and obesity point million death each year, large amount, huge amount, and around 39% of men and 40% of women are overweight. Now, in our Bangladesh, obesity, in case of male and female actually more obese, overweight, around 25% prevalence. If we compare with the male counterpart, only 12%. And we compare the rural and urban area. It's the urban area the highest rate, around 22%, and rural area around 14% prevalence. So not only to reduce the blood glucose or glycemic control, along with the reduce the obesity and control blood pressure, dyslipidemia, and other cardiovascular factors are equally important. And obesity is undoubtedly strongly associated with insulin resistance. And in the year of 2014, first GLP-1 drug FDA approved as an obesity therapeutic, name is Tirzepatide, and also 2021 next GLP-1 receptor which FDA approved, semaglutide. Now, Tirzepatide, it's a major breakthrough in the field of treatment of weight reduction, obesity reduction, as well as type 2 diabetes. It is the first FDA approved twin incretins are already mentioned as because it's the both are agonist GIP and also GLP-1. That means glucose dependent insulinotropic peptide. GIP and GLP glucagon-like peptide, both are agonists. It's so called, it's a twin incretin, and it is approved in May 2022. And this is the molecule, just up a new horizon in the field of treatment of reducing the obesity. Along with the type 2 diabetes mellitus. Here the structure, just a modification of the normal human physiological GLP-1 and GIP, some structural change that it can bind albumin and with a longer half-life. It's how it acts on beta cell to increase the secretion of insulin. Here the sodium channel is open, potassium channel is closed, and calcium enters into the cell and causing the depolarization and secretion of insulin in the basal level. At first the peak and later on basal, maintain the basal level. And we are getting foods, especially glucose, and it's handled by insulin, GLP-1, GIP, more natural physiological way. It's a balance. And how to act not only pancreas, Tirzepatide acts on the our hypothalamus, brainstem, to reduce the appetite and also the food craving, reduce the food craving and delayed gastric emptying, and also inhibit the glucagon, not to formation of the new glucose by gluconeogenesis. And indication of Tirzepatide, all of you know the type 2 diabetes mellitus, and but additional weight reduction when the BMI 30 kg per square meter or greater, and when overweight 27 kg per square meter, but at least plus one of the weight related comorbid condition like the hypertension or type 2 diabetes, dyslipidemia, obstructive sleep apnea, or any cardiovascular disease. So clear, when only BMI 30 kg per square meter or greater, and 27 kg per square meter or greater plus one of them. And it's due to structural modification of this molecule. It's a protect against metabolic degradation by DPP4 enzyme, and due to strong binding to plasma albumin, the half-life of tirzepatide approximately 1 week. And so it's a conveniently once weekly dose, subcutaneous. And this is the escalation of the dose. At first 2.5, 5, 7.5, 10, 12, and maximum dose 15 milligram weekly. So my one of the real world, that means my case just few days ago come after getting 1.5 month 2.5 milligram subcutaneous dose of Tirzepatide, and when the first time weight is 104 kg, and reduction after 1.5 month 4 kg, significantly reduction of the body weight, and feeling better also. There is no complication and side effect. It's a pharmacokinetic now, move on pharmacokinetics of this drug. Bioavailability 80% and half-life 5 days, and protein binding almost 100%, and it's excretion by urine and feces. And caution, or who should not use Tirzepatide, or contraindication. A patient with type 1 diabetes mellitus, patient with a history of pancreatitis, and men that is the multiple endocrine neoplasia type 2, and patient with personal or family history of medullary cell carcinoma of thyroid. And special precaution in pregnancy, usually pregnancy category D, and also OCP user, use of barrier method of contraception for 4 weeks after initiation and 4 weeks after each dose escalation. And lactation, there is no sufficient data Tirzepatide excretion in human milk, and better to use, not to use the lactating mother and also pediatric patient. And some untoward or side effects like dyspepsia, as because it causes the delayed gastric emptying, and sometimes causes the abdominal pain, loss of appetite, and nausea, constipation, rashes, etc. And SURMOUNT-1 trial is one of the most important trial for use of this drug in obesity. It's published in New England Journal, July 21, 2022. And it is double-blind randomized trial, and the total population samples volume 2,539 adults, and obese, overweight plus weight-related complication, but without diabetes. Here, 5% weight reduction at 72 weeks after getting this drug. 5 milligram, it's 85% patient is benefited. And when 10 milligram, around 89%, and 15 milligram, around 90%, and if you compare with the placebo, it's not so much higher, around 34%. So significantly reduce weight 5% at 72 weeks after getting Tirzepatide. And another primary endpoint, more than 20% weight reduction at 72 weeks, 30% who are getting the 5 milligram, who are getting 10 milligram, 50%, who are getting 15 milligram, around 57%. And SUMMIT-1 trial, another improvement of cardiometabolic parameter at 72 weeks, the HDL cholesterol increased 8%, and systolic blood pressure reduction around 7 millimeter of mercury, and triglyceride significantly reduced around 25%, and LDL reduction around 6%, diastolic blood pressure reduction around 5 millimeter of mercury. Another trial already finished and ongoing, SURMOUNT-2 and SURMOUNT-3. So due to time constraint, we cannot explain this explore this trial. Now, Surpass 1 trial. This trial compared with the Tirzepatide and placebo. If you come in case of Tirzepatide, 43.6 fasting plasma glucose milligram per TL reduction reduced by Tirzepatide, and glycated hemoglobin around reduction 1.87, and body weight 7 kg. If you compare with the placebo, only 0.7 kg. If you consider the HDL, Tirzepatide 4.8% and placebo 4.8% increase, but placebo, in case of placebo, reduction, rather than reduction, around the 4%, around 4%. And LDL, if we consider LDL, significantly reduction, around 7%, and placebo group only 1.6%. And triglyceride, around 19%, and placebo group around 5%. Now, Surpass 2 trial. Here, comparison between head-to-head trial, Tirzepatide and semaglutide. Here, Tirzepatide 5 milligram, 56 milligram per DL, fasting plasma glucose reduced, and glycated hemoglobin, body weight, LDL, triglyceride, all are significantly higher reduction, and increase of HDL around 6.8%, and semaglutide 1 milligram, all are, if you compare with the Tirzepatide, not so much good enough if you compare with the Tirzepatide. Both are once weekly dose. Surpass 3 trial, it's Tirzepatide versus Tresiba, insulin degludec, most newer molecule. Here, Tirzepatide 5 milligram glycated hemoglobin 1.93% reduction, and insulin degludec 1.34. No, not so much more higher in Tirzepatide group. And the body weight is so higher in Tirzepatide group, 7.5 kg reduction, and insulin degludec rather weight gain around 2.3 kg. And HDL increased 5% Tirzepatide group, and 1% is degludec group, and LDL 5% reduction in Tirzepatide, and insulin degludec 2%. Triglyceride also it's a better position in Tirzepatide, and waist circumference also. That means weight reduction and waist circumference both are higher in case of Tirzepatide group in Surpass 3 trial. And Surpass 4 trial, when it's compared with the insulin glargine, Tirzepatide glycated hemoglobin 1.3% reduction, and insulin glargine 1.34% reduction, and body weight 7.5 kg reduction. Rather, glargine increased 2.3 kg. Weight gain rather. And Surpass 5 trial, Tirzepatide versus placebo plus basal insulin plus minus metformin. Here only the placebo group is here compared. Tirzepatide 58 milligram per DL fasting plasma glucose reduction, and placebo 39%, and glycated hemoglobin 2.11% reduction, and body weight also significantly reduction by Tirzepatide group 5 milligram, and placebo only placebo group rather weight is increased 1.6 kg. So keep in mind, not only depends on drug, also we have to maintain our physical activity, non-drug therapy is a part of. And some take-home message we like to end of my talk. It's a really nice drug and superior if you compare with the semaglutide, insulin glargine, and the regular fasting plasma glucose, glycated hemoglobin, body weight, everything is the superior, or term we can use the non-inferior in biostatistical term. And BMI 27 kg per square meter, that means the overweight, plus one of the risk factor and hypertension, type 2 diabetes, dyslipidemia, obstructive sleep apnea, or cardiovascular disease. But when BMI 30 kg per square meter or greater, in case there is no disease or risk factor is required to use Tirzepatide. And it significantly improved cardiometabolic measure, already mentioned, such as blood pressure and waist circumference, and most convenience, just once weekly dose. And it demonstrates significant benefit in obese patient with heart failure with preserved ejection fraction. That means the diastolic heart dysfunction or diastolic heart failure is proved in phase 3 summit clinical trial. And it's the most important things and interesting. No dose adjustment of Tirzepatide is required in case of renal and hepatic impairment. And least but not last, healthy diet, exercise, lifestyle modification, yet now getting more importance along with drugs. Thank you all. Thank you very much. Thank you very much.